Hello guys, hope I'm audible and visible. Welcome back once again. So we will be continuing the same PYQ session what we had by afternoon. We had a session at 2. I have few more questions left. I'm just going to read through the questions and we'll discuss through them. Fine. So first things first, tomorrow at 9 a.m. we have an AAMT. We have made sure that this time we will live up to expectations and maybe even overdo it. Right. So please do attend the AAMT and give us positive, constructive criticism. You can message me directly, or you can put a mail to me at ranjith.ar@unacademy.com, or you can ping me on the Telegram group or Instagram. We do want a constructive criticism so that how we can take it forward from this point. I hope that will be a good learning experience for us. And there are multiple courses available for you tailored to your needs. You can enroll to any one of them with whatever code you have. If you don't have a code, you can use PathoCups. Fine. So we did see quite a few MCQs, quite a few PYQs, and I'm going to start from the last thing what we finished. The last question what we saw around 2 p.m. today was this about Mallory Helen and Mallory tank bodies, right? So if you have missed that session, I would just go through the same link. You must have the link available, so go through it and try to relook at it. It was all perfect same PYQs which came in the previous exams, right? So let's start today's discussion. It's going to be a very quick and a short discussion. Again, the same rules. I'm going to display a question. I want you to comment. These are simple old questions, so I'm sure you'll make a right answer. Fine. Good evening, Chakravarti. So let's go ahead. Okay, this is the question. Read through the question and let me know the answer. Maybe mute myself for a few seconds. Okay, answers? Anyone? Osmosis, welcome. Manoj, welcome. AE. Anyone wants to add to it? Again, blood banking is something which is very important for an INACT exam. I'm not saying that NEET will exclude blood banking, but it has more importance in INACT exam as compared to NEET exam. Fine. Okay, so storage of blood components is a very basic question. I'm sure you must have known this during your internship as well. Good evening, Osmosis. So answer A, like you guys said, is the right answer. RBC, can I say 2 to 6 degrees centigrade is the storage temperature for both PRBCs as well as whole blood? Yes, that's the same temperature. Platelet will be around 20 to 22 degrees centigrade. And FFP is at minus 30 degrees centigrade, right? It could be anything minus 30 or below. Minus 25 or below is also more than enough for an FFP as well as cryoprecipitate, right? So there are few questions which keeps repeating in blood banking. One is the storage temperature. The second about the blood bag components. And we'll quickly look up the difference of an SDP and an RDP. This question also keeps repeating. You'll see what do they mean. And Trali-Taco, it's an important question. And the routes of transfusion, right? The timeline. So I'm going to start transfusion now of a blood bank. When do I end it? Or in platelet I start now. When do I end it? Right? Those few protocols in blood banking, I'm sure you should know that. Fine. Okay. So now I'll come to this thing of SDP versus RDP, and I'll ask few practical questions in blood banking as well. Fine. How many of you have transfused blood here? How many of you listening to this lecture have transfused blood? If you're post-intern or an intern, you must have definitely given blood, right? That's one of the commonest thing which is expected from an intern. So if you get an RBC, let's assume you're getting a PRBC blood from a blood bank, it will be at 2 to 6 degrees centigrade. Do you warm the blood and give to the patient, or do you give it the blood directly? As I said, it will be in 2 to 6 degrees centigrade. Do you give the blood directly to the patient? Is warming essential or not essential? That's a very practical and a basic question. Do you warm the blood or you don't? Okay, Osmosis has gone with warm the blood, right? Anyone else? It's essential. Okay, Hamani, fine. Okay, first of all, you must have done this. See, when I was an intern, I have also done that, right? You should not warm the blood. It's not needed. It's not essential. Fine. Warming a blood is not at all essential. It's not required, right? So few things which we follow in an internship, if it is ideal, I can easily replicate to a competitive exam as well. But you don't want to warm, you don't want to vomit at all. You take the blood bag, directly put into the line and transfuse it. It will not cause hypothermia. If I'm going to give one blood, like 1 unit of blood, which is 350 ml of blood, it is not going to cause hypothermia, nothing will happen. It's just going to be in drops, right? You'll have 1 ml transfusion at a very, very slow rate. It will not cause a problem at all. Unless you're following a massive transfusion protocol, like you transfuse like 10 units or 20 units, that time warming is essential. And I have to warm in a normal, regular room temperature water at that time. In a routine blood transfusion, you do not require to warm the blood, fine? Second question, if you have got a blood transfusion is very common in obstetrics ward, right, in the labor room. So if you got on blood, let's assume a patient is having a postpartum hemorrhage, where blood transfusion is definitely essential. So they will ask to get 1 or 2 packets ready because blood bank might not give frequently, right? So have you ever gotten a blood from the blood bank and kept in your fridge? Have you done that? I have done that personally when I was an intern. Because that time we will say that blood bank officials don't respond to us. So I get 2 or 3 units of blood and we keep in the fridge, right? That is ultimately a wrong procedure. Please don't do it when you become an intern, when you become a postgraduate, right? So because when you take a blood from a blood bank, it should be transfused to the patients. That's the only route. If it is not transfused within 30 minutes, the entire blood bag is waste. You have to remove it, right? Okay. If you have to run for each bag, that's the best protocol, Chakravarti, right? So that you should never ever store it. Once it is removed, the blood transfusion should start within 30 minutes. If you're not able to start within 30 minutes, the blood should be returned to the blood bank, and in the blood bank, they'll discard the blood. That's a wasted blood, right? So please don't buy 2 or 3 and store it in your fridge and give whenever you want. That's not the way to do it, because I cannot assure that my fridge temperature is always kept at 2 to 6. You keep it open, you keep it closed. Whenever the temperature fluctuates, I'll have lots of changes in the blood. Not only that, infection, sepsis becomes a huge trouble, right? So please don't do these things, right? I'll come to the next part of the question. SDP was RDP. What do you think SDP is and what do you think RDP is? What is SDP and what is RDP? I'll try to erase the rest of them. What is SDP and what is RDP? SDP stands for single donor platelet, right? SDP stands for single donor platelet and RDP stands for random donor platelet, right? That's the two difference of SDP and RDP. Your single donor platelet and a random donor platelet, fine, great. Versus random donor platelet. So first we'll understand what do they mean, and then we'll understand what is the difference between an SDP and RDP, right? So when I say random donor platelet, when I have platelet from you as well as platelet from me, though if our blood groups are different, do you think will there be any problem with platelets? Can I donate platelets for any patient to any patient? That's not much of a trouble. Though I have a little bit of plasma left, we'll have a little bit of problem, but not a major trouble, right? So what we do is, we take like 10 patients blood, we separate the platelet and we pool them. We pool them means we mix them, right? That's what I mean by random donor platelet. You take 10 or 20 patients blood, you separate it into PRBC, packed red blood cells, and then I have platelet component which is separate. Via centrifugation, platelet automatically comes up. I take the platelet alone and I mix 10-20 people's platelet and I keep them. That is called as random donor. Can I tell? Though even if your blood and my blood are same group, can there be minor blood group antigens which will be different? Because we don't test the minor blood group antigens. So is there a possibility if I mix 2 or 3 or 4 people's plasma, there can be reaction and the number of platelets in the sample will reduce? It can happen, right? So in other words, random donor platelet will have less of an yield. I won't have such a high yield. But when I say single donor platelet, you must have heard about a procedure called as plasmapheresis. Yes, you must have definitely heard about that. So what we do in single donor platelet is, we just take a patient, you just connect them to the plasmapheresis machine. You put a needle here. The entire body's blood will be taken outside, will be run in the machine, and via the other arm, the same blood will enter. So during the process of running, I don't do anything. I don't take any RBC, no WBC, only the platelet will be filtered. I can even filter stem cell. There are multiple filters that. So that's a single donor platelet, right? You have a plasmapheresis machine. If possible, when I go to the hospital next time, I'll show you an image of plasmapheresis machine. Fine. I just run it to the machine. I remove the platelets alone, and this is from a single person. The yield will be more. The response will be more, right? So this is the difference between SDP and RDP. And this is a temperature for your normal blood components, 2 to 6, like we saw. This came in an exam, right? If I keep a platelet with agitation, what do you think is the half-life? If you have a platelet which is kept with agitation, which means it keeps on shaking, what do you think is the half-life? It's stored for 5 days, like it's written above, right? If I have a platelet without agitation, there is no movement at all, what do you think will be the half-life? That came in your INACT exam. Without agitation, the platelet can live only for 24 hours. It cannot live beyond that, right? With agitation, it can live for 5 days, and without agitation, it can live only for 24 hours. Beyond that, the platelet should be discarded because it becomes wasted, right? So if a platelet life is being asked, look for that. And if for whole blood and PRBC, if the lifespan is being asked, it totally depends on what component I have. Is it SAGM or what component I have? Based on that, the half-life will vary. Starting from 21 to 35 to 42 days. It varies based on different things, fine? Okay. I said this is the difference between SDP and RDP. SDP, the yield will be excellent. Post-transfusion, platelet can rise up to 60 to 70,000. If you look at RDP, it's 10% of it. 5 to 7,000 only I can have a rise. SDP, the platelet yield is also more. RDP's platelet yield is obviously less. Again, the yield of platelet is 10 times more in SDP. That's why the rise is also 10 times more in SDP, fine? And this is a very, very important thing as well. When you give a random donor platelet, which means I am taking as a component of blood donation, I cannot donate it very frequently. But in a single donor platelet, I can donate within 2 days. Single donor platelets are extremely useful for patients who are require leukemias, bone marrow transplant. I do require lots of platelets. So if there's a relative who's ready to do it once in 2 days, sit with the machine and do it, that will be amazing, so that I can have a very good platelet yield as well, and it will not harm the patient also more, right? These are two main differences between your platelets, okay? Next. Fine. Next question. Comment on whatever comes to your mind. Comment on the answer. Whatever you think is correct, comment on it. I'll answer your question, Chakravarti. Sorry. Okay, C. Great. Okay, if a patient is donated a random donor platelet, again, by protocol, I have to wait for the same duration of blood transfusion next time. But if there's a dire need, and if the patient's health condition is fine, it can be shortened and the patient can give it. Because I don't lose blood per se. The patient's platelet is fine, the patient health condition is fine, they can donate it again, fine. Great. This was again a PYQ. It's completed within 4 hours. It has to be completed within 4 hours. Let's assume, I'll give a practical scenario. You are starting a blood. There's definitely a possibility. Yes, Manbar, it should be started within 30 minutes. There's definitely a possibility you have a 350 ml of blood, and the entire blood is not gone in within 4 hours. At the end of 4 hours, let's say I'm left with 100 ml back in the bag still, but 4 hours is completed, right? So what do you do with the 100 ml? Do you push them, or you stop and you discard the blood? There's something happening after 4 hours. I'm still left with 100 ml of blood because maybe the line was not perfect. The flow rate was very less. What will you do? If anything remains after 4 hours, it has to be discarded. Please don't use them, right? Any blood component present after 4 hours, anything, even if 200 ml is left, it has to be discarded. That's a rule. Maximum within 4 hours, right? Do you guys know what is the limit for an platelet? FFP, is there any limit at all? If there is a limit, what do you think is the limit for platelets in FFP? Like, when should I discard it? Can I keep it forever? 4 hours or 1 hour or 2 hours? Anything like that? Okay. So this is a table from WHO. Please look at this. The whole blood and PRBC should be started within 30 minutes and should be completed within 4 hours. If there is anything left beyond 4 hours, please discard them. Platelet, FFP as well as cryo, it should be immediate. The immediate component should be emphasized very much for FFP and cryo, because if you wait FFP and cryo for even for some time, the heat level factors will get destroyed, right? So this as early as possible, immediately, and it should be finished within 30 minutes. Anything remaining after 30 minutes, again I have to discard it, right? These are the rules to be followed during blood transfusion, fine? Okay. Let's see. This is a question which came in 2018 AIMS. See if you can answer this. Because in 2016 is when the last WHO of the hematolymphoid malignancy came. Okay, any answers? I'll come to essays edit. Just give me a second. Is my video stuck? No, fine. Okay, Tipayan has gone with A. A, C, D. Okay, we have different answers, which means it's clear that you're not gone for 2017-18 PYQs. It's fine. We'll read them occasionally whenever it's required. Fine. First, coming to your question, yes, I said it. How are they discarded? It's a blood, right? It's a human anatomical waste. Which bag do I put and how do I discard it? It seemed like anything. It's of your biomedical waste management, right? You discard the same way you discard any anatomical tissue, because blood is also considered like that, an infective anatomical tissue. I'm going to discard it, I'm going to incinerate it, and I'm going to do whatever I do in your routine biomedical waste management. Fine. Okay, yeah, hello back. Okay, coming back to this. So this 2016 is when the WHO came. Immediately after the new WHO came, AIMS had this question. AML with hyperdiploidy is not one of the 2016 update. Rest all three of them were the new entities post 2016 WHO, right? These were the provisional entities which is added in 2016-17 classification. AML with BCR-ABL, ALL with BCR-ABL, T cell precursor, NK cell lymphoblastic. This is important, remember them, because there are lots of updates which is going on in IAMP. It might come in an exam, right? BALL with IAMP 21 is again a new classification. And this. Have you read about Runnex before? Have you heard this name before? I'm sure you must have heard this name before, right? Where have you heard them? You must have read them in something different. Have you read Runnex mutation or your translocation? Okay, have you heard this? Translocation 821. Translocation 821 is also a classical finding in AML, right? Right. So 821 translocation has the your Runnex, right? So Runnex generally, the older one is Runx1 translocation, right? That's different. So translocations and mutations are not the same. The outcome might not be the same, right? So what the new classification added was mutated Runnex. If you remember 821 translocation in acute myeloid leukemias, they have a good prognosis or a bad prognosis. The 821 translocation in AML, the prognosis is good or bad? They have an extremely good prognosis, right? 821 translocation has a good prognosis, but a mutated Runnex has a bad prognosis. So I want you to listen carefully to what the question is being asked. If it's a Runnex translocation, the prognosis is good. If it's a Runnex mutation, they do have a very bad prognosis, right? Both are the same molecule. Translocation will have a different effect and mutation will have a different effect. So please carefully observe what the question is asking and based on that give the answer. Yes, Rajat. Okay. This question we had discussed before. Just to make sure you don't make any mistake again. What's the answer? I want everyone to write the correct answer. comment on the correct answer. Okay, it should be 100% blood, right? It should be 100% option A, right? The learning point, see, you had a mistake and there was a controversy when the question was discussed, right? So when you have anything where there's a mistake, the only thing is, what do I learn from them? You have to look for this for every mistake of yours as well as for someone else's mistake. I'm going to learn from them. The learning point from this is, the question had a confusion because of this, right? There's a confusion of benzidine or benzene. That's the reason there's lots of hue and cry about this question. The confusion was this. Benzidine was, some of the students said benzidine, some of the students said benzene. So there's a confusion of blood and your bladder cancer, right? So obviously benzidine goes for bladder and benzene goes for blood. So why there's a confusion here is, I am relying on a fact. Facts are easy to forget. That's the reason after the exam, some of them said benzene and they wrote this, and some of them said benzidine, so they wrote this. So please don't rely on any fact for a question which has a scenario. When the question has a scenario, I want everyone to concentrate on the scenario, because as an intern, you are very comfortable with asking a case history, examining the patient. You're not comfortable with fact. That's true for every doctor. No doctor is comfortable with fact. If you have a doubt, go back, call your surgeon and ask them TNM classification of breast cancer. You will know, they won't know. Tell them stage 3, what all will come. They won't know. No doctor is set to read fact. You are set to process, you are set to manage the patient. So when you have any question, ignore the factual points. Concentrate on the history. Have a history of fatigue, multiple infections. So do you think a patient with an bladder cancer will have fatigue and multiple infections? They don't, right? Fatigue and multiple infections means I'm having patient with anemia, I'm having patient with leukemia, right? That's what I mean by fatigue and your multiple infections. Obviously, fatigue and multiple infections means there's something in the bone marrow, maybe pancytopenia also. So I'm going to go for blood-related tumors only. History is more important for any question rather than a fact. Try to have less dependency on the fact. If it's a one-liner, I can't do anything, then obviously benzene and benzene is there. Please concentrate on the history. Ignore the fact. From now on, whatever GT or whatever question you attend, make sure you're getting tuned for the history, process, diagnosis and management. That will make it much more easier for you than relying on the fact, right? And next question is a fact. I know this, everyone will write the correct answer, because this is one which you never forget from your first year. Comment on the answer. Whatever comes to your mind, comment on that. It's a classical case, right? Crumpled tissue paper appearance, hepatosplenomegaly, and the answer has to be your Gaucher's glucocerebrosidase, fine. There are a few important points in Gaucher's. Can I say Gaucher's disease is the first disease where enzyme replacement was successful? Yes. Gaucher's is the first disease where enzyme replacement was successful, right? Still we are struggling with enzyme replacement for many diseases. Gaucher's is the first one where enzyme replacement was successful, right? Next thing. Have you heard about something called as pseudo-Gaucher cell? Have you heard about anything called a pseudo-Gaucher cell? Have you heard about that? If so, in which condition? It looked like a Gaucher cell, but it's not a Gaucher cell, it's a pseudo-Gaucher cell. Okay, you must have definitely seen the Gaucher cell, right? If you have seen the image of a Gaucher cell, if you can remember the color of the cytoplasm, the crumpled tissue paper color, what will be the color of the cytoplasm of the crumpled tissue paper? Pink or blue? How did it look? You must have seen the crumpled tissue paper image multiple times. How did that look? It was in blue color cell, right? It was a bluish cell. That's how a crumpled tissue paper will look. That was in bluish color cell. Sorry. Okay, it's a bluish color cell. It is blue, right? So they have a bluish color cell. Then you also must have read about Burkitt's blast. The Burkitt's blast cytoplasm, can I say that is also blue in color? The cytoplasm of Burkitt's blast, it is with multiple vacuoles, right? So in other words, if you have a macrophage And if the bone marrow is extremely highly proliferating, this macrophage consumes all the dead particles and they become bluish. There will be bluish cytoplasm of macrophage in a very highly proliferating bone marrow. Okay. Whenever there is a highly proliferating bone marrow, the macrophage eats the dead cells, not able to process them. They'll have the retained protein and elements and everything, and they look bluish in color. So these macrophages in a highly proliferating bone marrow looks like a Gaucher cell, and they are called a pseudo Gaucher cell, right? Remember them. This can come in an MCQ. It has come in an FMG paper long back. So when I have a pseudo Gaucher cell, my thing is not this theory. My role is to diagnose, that's all. So can any one of you tell me at least one example of a disease where you will see extremely high proliferation of bone marrow? And in those diseases, definitely I'll see pseudo Gaucher cell. Any disease which comes to your mind for extremely high proliferation of bone marrow. Great. So PK started with that. Can I say in chronic myeloid leukemia, the bone marrow will be extremely proliferative? Because it's your, I'll come to it in Burkitt's. Because in CML, I'll have your erythroid, myeloid, as well as megakaryocyte proliferation. That's one for sure, right? That's one for sure. Second, Dipayan, when I take Burkitt's, in Burkitt's, where do you think the major chunk of proliferation is? Bone marrow or lymph node? The majority of the proliferation in Burkitt's happens in bone marrow or lymph node. It generally happens in the lymph node, right? It doesn't happen in the bone marrow. Unless I don't have an infiltration in the bone marrow, it doesn't happen. So I'm going to ignore them for some time now. It might not have the same color in the bone marrow. Again, osmosis, Ewing's can be highly proliferating, but again, Ewing's is not something which is primary to the bone marrow. Okay, I'll give you one more clue for the second cause. There is a disease where my bone marrow proliferates a lot, and that gives an appearance of your true cut appearance of the skull or hair on end appearance of the skull. Which disease is that? There will be lots of proliferation in the bone marrow in that disease, which expands the bone marrow and has the hair on end appearance. Can I say it's thalassemia? Right, great. Thalassemia and sometimes sickle cell anemia, but most likely thal, right? Great. So in CML, as well as in thalassemia, there's an extremely high proliferation happening in the bone marrow, and in both of them, you will see something called a pseudo Gaucher cell. Because Gauchers has been known to everyone, and I'm sure you know the answer of Gauchers, how they look, and even if its image is given. Pseudo Gaucher looks the same way. There's one more name for pseudo Gaucher. It's blue in color and it's a macrophage. The other name for macrophage is histiocyte, so we call them a sea blue histiocytes. This is the other name for Gaucher cell, because macrophage is histiocyte and it's a sea blue colored histiocyte. Fine? Clear? Okay, great. Again, read the question, comment on the answer, we'll discuss it quickly. Okay, the parents again started the poll with option A as the answer. Anyone wants to defer or add on to it? A, Thymoma. It's a simple one, right? Okay, let's see. Fine. It's a 60-year-old person who came to the OPD with discomfort in the chest. On evaluation, the hemoglobin was low, right? And there's a mediastinal mass there. And the retic count was 0.5 centimeter. That also is extremely low, right? And the patient was diagnosed to have a pure red cell aplasia. This is giving everything in the platter. You have the paraneoplastic syndrome diagnosis. You have the main diagnosis, which has been asked, right? A mediastinal mass with pure red cell aplasia. There can be only one person which can fit into this picture. Has to be Thymoma, right? Can any one of you name any other well-known paraneoplastic syndrome of Thymoma, which a famous celebrity in our country has? There's one more well-known paraneoplastic syndrome. What is that? Anyone? Aplastic anemia, no. Myasthenia gravis, right? Myasthenia gravis is a very, very well-known paraneoplastic syndrome. Aplastic anemia will not happen in Thymoma. Pure red cell aplasia happens in Thymoma, right? Okay, myasthenia gravis, fine. It's 0.5% of retic count. Okay. So this retic count is less or high? Yeah, Amitabh asked that. Not thymoma, your myasthenia gravis. The retic count here particularly is low or high? It's definitely a very low retic count, right? So if it is not a pure cell aplasia, name at least 2 more cases where you can see a 0.5 reticulocyte count, or 2 more cases where you will see lower retic count. Just 2. There are plenty of them, at least 2 more. Apart from aplastic anemia, fine. Anything with low retic count? Because aplastic anemia is very easy. Apart from aplastic anemia, tell me 2 things with low retic count. Okay. I'll ask you leading questions. Tell me what will happen. Can I say in a patient with anemia of chronic disease, there will be bone marrow suppression? Yes, great. That's one. Anemia of chronic disease. I'll take whatever Rajat said. Though I'm not going to primarily depend on AML, I'll take MDS. Because AML, unless it's a myeloid problem, your erythroid problem, it might not suit it to. MDS will have low retic count. Anemia of chronic disease will have low retic count. Aplastic anemia has low retic count. What do you think will be the reticulocyte count of megaloblastic anemia? Right, perfect. Right, megaloblastic anemia also will have low retic count. Iron deficiency anemia also has low retic count. In other words, can I say the predominant of the anemias except hemolytic anemia group, everything will have low retic count? It will, right? So elevated retic count is a characteristic finding seen in hemolytic anemias. In rest everything, my reticulocyte count will be low only. Fine. Okay, great. Okay, comments on the answer. We'll discuss something interesting about the disease because I'm sure everyone knows about the disease. Answer? The simple one, right? This person is torturing you from your second year practicals, right? The caterpillar nuclei, the Ashoff body, Anishoff cells. Sorry. Okay, the Ashoff body and Anishoff cells has been torturing you for many years, right? Though there's a history suggestive of it, it's going to be caterpillar cell and it's going to be your Ashoff bodies, right? I'm not going to discuss about rheumatic arteries or Ashoff body. I just want you to observe and I want you to learn things which might not be given in the book. Go and learn, research more things and read, right? You must have read about one of the criteria of rheumatic heart disease as Sydenham's chorea, right? What is the other name of Sydenham's chorea? There is a very fancy term for Sydenham's chorea. What is that? The fancy term. Have you heard about something called as Saint Vitus dance? You have not heard of that? I'm sure you must have heard of Sydenham's chorea. Haven't you heard of Saint Vitus dance? Right, you have heard of that, right? Great, right? So Saint Vitus dance is the other name for Sydenham's chorea. That information is regularly asked in Viva, right? That is not something very unimportant. It's extremely important, right? So if I can ask you one more thing, can I say Sydenham's chorea is not a very early finding in rheumatic heart disease? I can see this chorea even after like 6 months or 10 months after throat infection. Is that right? That's right, right? I don't see them early. You can see them very late as well, right? Right? So rheumatic chorea, I can see them extremely late also. It's not always an early finding, right? So now, if it is a late finding, during that finding of your Sydenham's chorea, do you think ASO titer will be positive? Or will the patient remember the history of sore throat? Or will the patient have any acute carditis or joint pain? Will there be anything of the symptoms? Or your erythema nodosum, anything? You won't, right? I want to take whatever Rajat said. He said it's not early but specific. I'm calling something a specific, but no other finding will be there, right? That's very characteristic. I'll have no other findings of rheumatic heart disease. I'll have a single chorea, but still I can call it very specific for rheumatic heart disease. You should have wondered why whenever you read that statement, right? Well, see why. Why is the answer to why is there in Saint Vitus dance? So Saint Vitus is like any guru in your Middle East, in Europe. So for Saint Vitus, there used to be an annual ritual where people used to dance in front of a statue and they shout. We have many customs like that. The custom for Saint Vitus, people in groups, they used to come and dance like anything and they shout like anything, right? So what happens after Saint Vitus dances? The throat, the voice changes because the people shout extremely. The voice changes. That is the most important thing. So it is said to be that whoever goes to Saint Vitus festival, they have a voice change, they have a historical voice change, they shout and they dance. The dance is choreotheatoid movements. So rheumatic chorea is called as a Saint Vitus dance because in rheumatic chorea, and it is the only chorea where you'll have voice change and your chorea. There'll be no chorea with voice change. So this is more important. The reason for Saint Vitus dance is that, right? You must have read about many things etiology for chorea. Huntington's chorea is also an etiology. Anything with problem in the brain will have that. But none of those chorea will have voice change. And none of the other chorea is called a Saint Vitus dance. So if you see a patient with rheumatic chorea, next time ask the parent, is there a change in the voice? Because this is the only chorea which will involve the laryngeal musculature. And this is the only chorea with voice change. That's why it is specific. It's not just a chorea. The chorea plus voice change makes it diagnostic of rheumatic chorea. Even though I can see it an year later, still I can pick it up because of the voice change, right? So next time, if at all you see a patient with rheumatic chorea, though the incidence is less, try to elicit this, fine, right? Okay, thank you, Nostalgic Nishan. Okay, so please have a look at this, fine. And whenever you are reading anything in medicine, if you have an analogy, you must have read about many analogies, right, in your life. You have many things like strawberry cervix, strawberry tongue, many things. Go and see why there is an analogy, right? That's going to be much helpful for you than just reading the fact, fine. Okay, I'm going to end up with this. So if there's any doubts, do let me know. If not, we'll catch up soon. I hope your exam happens whenever it's supposed to happen. We'll leave it to the NB and the officials. And if it happens on 21st May, we'll keep finishing this PYQs on an intermittent basis on YouTube, fine. Okay, any doubts? No doubts? Okay, if there are no doubts, we'll call it a day, fine. Thank you, Rajat. Good night. Have a great weekend. Bye-bye.